Good afternoon, everyone. My name is Saimoeta Parampo, and today I will be presenting on use of Sesquient, which is fosphenytoin sodium injection in pediatric status epilepticus. Today's learning objectives include summarize pathophysiology and treatment of status epilepticus, understand the new injection formulation of fosphenytoin sodium, appropriate recommendations of Sesquient in pediatric population. So what is status epilepticus? It is a condition where seizure can last greater than or equal to 5 minutes or two or more discrete seizures between which there is incomplete recovery of consciousness. So you can see it as a medical or neurologic emergency, and it is specified into two types, status epilepticus and refractory status epilepticus, which is when a status epilepticus patient is given an benzodiazepine as well as additional first-line anti-seizure medication. However, their seizure symptoms continue to go on and does not resolve with these medications. Today we will be focusing on status epilepticus. So in terms of pathophysiology, it results from inability to normally abort an isolated seizure either due to ineffective inhibition or due to abnormally persistent excessive excitation. So in terms of prevalence, the highest incidence in neonatal period is seen and declines until approximately age of 5. From neonatal to a year-old age range, there are approximately 135 to 150 incidents per 100,000 people. Across the pediatric lifespan, you can see about 17 to 23 out of 100,000 children experience status epilepticus. Overall mortality of status epilepticus is lower in children than adults at around 3%. Children presenting with status epilepticus as their first seizure only have a 30% risk of later diagnosis of epilepsy. In terms of the causes of status epilepticus, febrile status epilepticus is one, as well as trauma, infections, severe hypoxic encephalopathy, non-compliance with anti-epileptic medications for patients who have been diagnosed with epilepsy previously, metabolic abnormalities, intracranial tumors, cerebrovascular diseases. And these are a few of the causes I have listed. However, there are many other causes that can lead up to status epilepticus in children. In terms of management, you want to make sure supportive measures are carried out immediately. So making sure the airway is open, patient is breathing, and circulation is fine. For treatment, the first line is benzodiazepines. So you commonly see lorazepam, diazepam, and midazolam used. There are different formulations such as IV, intranasal, rectal, although that might not be used as often due to the way it's administered. However, a key new formulation to learn about is Valtoco. It's an intranasal diazepam that was approved in 2020 and is excellent in non-hospital settings for family members or caregivers to administer to patients who have epilepsy. Second line includes phenytoin, fosphenytoin, phenobarbital, valproic acid, and levetiracetam. If patient doesn't stop seizing 5 minutes after any of the second line options are used, you may use phenobarbital or fosphenytoin phenytoin based on what was used previously. So if you gave phenytoin as your second line option, make sure that you use phenobarbital as the third line medication. In terms of indications, For pediatric population, we are focusing on the use in short-term substitution for oral phenytoin in patients 2 years old and older. You should only use this when oral phenytoin administration is not possible. This is the only FDA-approved room temperature stable formulation of fosphenytoin sodium, and it was approved on November 5th, 2020. In terms of mechanism of action, it is a prodrug of phenytoin. Although the precise mechanism is not established, it is thought to involve voltage-dependent blockade of membrane sodium channels, resulting in reduction of sustained high-frequency neuronal discharges. The following are contraindications to the medication: hypersensitivity to fosphenytoin, phenytoin, other hydantoins, or any inactive ingredients of Sesquient, sinus bradycardia, sino-arterial block, second and third degree AV block, and Adams stroke syndrome, history of prior acute hepatotoxicity attributable to Sesquient, fosphenytoin, or phenytoin, as well as co-administration with delavirdine, which is an anti-HIV agent. Phenytoin can substantially reduce the concentrations of this medication, which leads to a loss of virological response and possible resistance. Common side effects seen in the pediatric population is vomiting, nystagmus, as well as ataxia. In terms of drug interactions, there are two categories you can separate this into. So drugs that increase phenytoin serum levels and drugs that decrease phenytoin serum levels. So the ones that increase are anti-epileptic drugs such as topiramate, ethosuximide. Some common azoles that you can see is fluconazole, and gastric acid reducing agents such as omeprazole and cimetidine. Agents that can decrease phenytoin serum levels include antineoplastic agents usually seen in combination, such as bleomycin, methotrexate, antiviral agents such as ritonavir, and other agents such as diazepam, rifampin. Some of the monitoring parameters for this medication includes the total phenytoin serum level. So the therapeutic concentration that you want to get the patient to is 10 to 20 micrograms per milliliter. And in terms of unbound concentration, this is 1 to 2 micrograms per milliliter. It is essential to wait approximately 2 hours after the IV infusion is complete to draw these levels, because having the full conversion to phenytoin is important. ECG, blood pressure, respiratory function are other parameters that you want to monitor. A few things to caution about this medication is the cardiovascular risk associated with rapid infusion. So for this reason, they have a max rate of 0.4 milligrams of phenytoin per kg per minute in pediatric population. This can present with risk of adverse cardiovascular reactions such as severe hypotension and cardiac arrhythmias. Severe complications are most commonly encountered in critically ill patients, elderly patients, and patients with hypotension and severe myocardial insufficiency. However, cardiac events have also been reported in adults and children without underlying cardiac disease or comorbidities, and at recommended doses and infusion rates. Withdrawal precipitated seizure is another one. So anti-epileptic drugs should not be abruptly discontinued because of the possibility of increased seizure frequency, including status epilepticus. Lastly, serious dermatological reactions. So fosphenytoin sodium injection, or Sesquient, can cause severe cutaneous adverse reactions, also abbreviated as scars, which may be fatal. Reported reactions in phenytoin treated patients have included toxic epidermal necrolysis, also known as TEN, Stevens-Johnson syndrome, also known as SJS, acute generalized xanthomatous pustulosis, also known as AGEP, and drug reaction with eosinophilia, and systemic symptoms known as DRESS. In terms of storage, this medication is different from Cerebrix, which is also a fosphenytoin formulation, because this medication can be stored at room temperature, whereas Cerebrix has to be refrigerated. This can be convenient for people who may not be able to store a refrigerator in whatever setting that they may be, whether it be in the hospital room or in an ambulance. Injection vials are single doses for this medication, so you want to make sure to discard any unused product after it has been opened. There are two different doses for this medication. First is the non-emergent loading dosages. For pediatric, which is including 2 years old to less than 17-year-old, your dosage is 10 to 15 mg of phenytoin per kg, and the infusion rate, of course, is to not exceed max rate of 0.4 mg phenytoin per kg per min. For the maintenance dosage, it has the same age criteria again. However, it is separated into initial maintenance dosage and maintenance dosage after initial maintenance dosage. So for the initial maintenance, you want to give 2 to 4 mg of phenytoin per kg, and dose given 12 hours after the loading dose. And for the maintenance dose after this initial dose, you want to give 4 to 8 mg of phenytoin per kg per day in divided doses, and continue every 12 hours after the initial maintenance dose has been given. And of course, with these, same max rate of 0.4. In terms of recommendations on the use of Sesquient, due to risk of cardiac and local toxicity associated with IV Sesquient, oral phenytoin should be used whenever possible. When treatment with oral phenytoin is not possible, Sesquient can be substituted at the same total daily phenytoin sodium equivalence dose. Safety and effectiveness of Sesquient in pediatric patients for treatment of generalized tonic-clonic status epilepticus and prevention treatment of seizures occurring during neurosurgery have not been established. However, the safety and efficacy for short-term substitution of oral phenytoin have been established in pediatrics greater than or equal to 2 years old. Supported by evidence from safety studies in adults comparing IV fosphenytoin to IV phenytoin, PK data in healthy adults comparing Sesquient to IV fosphenytoin, and safety data of Betadex sulfobutyl ether sodium in pediatric patients greater than or equal to 2 years old. So as of now, they have data for greater than or equal to 2 years old, but no safety data on Betadex sulfobutyl ether sodium use in pediatric patients below the age of 2. The FDA package insert did mention that one double-blind study in adult patients assessed infusion site tolerance of equivalent loading doses of 15 to 20 milligrams phenytoin per kg of IV fosphenytoin infused 150 mg phenytoin per minute, or phenytoin infused at 50 mg per minute. And this study demonstrated better local tolerance, such as pain and burning at the infusion site, fewer disruptions of the infusion, and a shorter infusion period for fosphenytoin treated patients. And that comes to my conclusion with my references. So these are the references I have used for this presentation today. And if you do have any questions, feel free to email me at my email, simon.edaprampo@tphsc.edu. And thank you so much for listening to my presentation, and have a great day. Thank you.